This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh, still in the Paul C. Gaffney Division of Pediatric Hospital Medicine, coming to you again with another very exciting topic. Of course, before we start, we have to say thank you to the University of Pittsburgh. They have given a graciously free CME credit, AMA Category 1. To anyone who's listening, feel free to go to the link at the bottom of the podcast description, click on it, get a free login, answer questions that I write when I do not make them hard, or I try not to, and then you get your free AMA Category 1 CME credit. This is a topic that has been burning through our listserv, the news media, all over. You've seen this a lot in terms of the pandemic, what it's done to the mental health of the country and what it's done to admissions and ER visits for mental health reasons, and the pediatric population has unfortunately not been spared. And so we wanted to talk about just what's going on and then potential de-escalation techniques if you're a hospitalist and you're taking care of a pediatric patient who's admitted for a psychiatric reason, schizophrenia, severe anxiety, depression, mania, anything, and you're not sure what to do. So we wanted to come up with something to help with that. And to do that, I could not think of a better expert guest than the guest who was gracious enough to give us her time. So let me introduce her. We are fortunate enough to have Dr. Cristin McDermott with us today. Dr. McDermott graduated from the University of Connecticut School of Medicine in 2012 and completed a triple board residency program in pediatrics, general psychiatry, and child and adolescent psychiatry here at the University of Pittsburgh Medical Center in 2017. She's board certified in each of the three disciplines I just mentioned and is on faculty at the University of Pittsburgh in the Department of Pediatrics and Psychiatry. Dr. McDermott practices as a pediatric hospitalist right here in the Paul C. Gaffney Division of Pediatric Hospital Medicine. I'm fortunate to have her as one of my partners, and as a child and adolescent psychiatrist with her primary role on the consult and liaison service at UPMC Children's Hospital of Pittsburgh. She also serves as the Associate Training Director for the Triple Board Program at UPMC. So, Dr. McDermott, thank you very much for joining us today.
Thank you so much for having me, Tony.
All right. Let's do our conflict of interest statements and get them out of the way. As part of CMU, we have to do that. I will go first, Cristin, and kick it out to you. I have nothing to disclose.
I have nothing to disclose.
So, Cristin, this has been all over the listserv. This has been everywhere. News media is talking about it. CNN, NBC, Fox, everyone's really discussing this. Can you help us understand the problem? What's going on for mental health since the pandemic, hospitalizations or ER visits or any of this?
Yeah, so I think one of the ways to think about this is actually to look at what was happening pre-COVID and then move through what's happening during the pandemic. So well before Corona even hit these shores, we were having increasing rates of depression and anxiety in children and adolescents in the U.S. and an increase in suicidality. Be that suicidal thoughts or suicide attempts, these were all things that the CDC was following and noting were on the rise. We were also already seeing more ED visits, hospital admissions, and PCP visits for behavioral health concerns. I think one recent study that came out in Pediatrics, actually from Dartmouth, that addresses the pediatric mental health boarding crisis, had some really interesting statistics that are just broad but important. So in the U.S., 1 in 6 youths have a behavioral or mental health condition. Right?
1 in 6.
1 in 6, with treatment costs that are upwards of $10 billion a year. So this affects a very large portion of our population. Again, we're only talking about children and adolescents. We're not talking about what happens after 18. So I think as importantly as the number of kids who suffer from these diagnoses is that about half to 75% aren't seeing behavioral health specialists for these problems. They're seeing PCPs because of access, which is great. We're so pleased that our pediatricians and family docs are helping to manage these patients. As I mentioned earlier, about 50% of these PCP visits have some component of behavioral health mixed in.
Those numbers are just astounding. 1 in 6, half of those aren't seeing psychiatrists, PCPs are managing. And you're saying this was before the pandemic.
This is before the virus. This was already on the rise. And I think the other thing that's really important to note is that many of these kids receive behavioral health treatments and therapies through school. And so we'll see how that affects things later, particularly with the pandemic. But many of these services are school-based.
Wow. I was just reading an article was done in JAMA Psychiatry. It just came out, February 3rd, I believe, where they compared ED visits between March and October of this year, of 2020 versus 2019. And the ED visits for psychiatric purposes were significantly higher.
Mm-hmm. Yeah, and this may be a similar number, but I think the CDC had also reported that U.S. hospitals between April 2020 and October 2020 saw a almost 25% increase in kids between the ages of 5 and 11, again, for mental health concerns, and about a 30% increase for teenagers, 12 to 17.
So we've heard a lot, the lay media, about what could be bringing this on. What is it about this pandemic, you think, that's causing this in everyone, but even in pediatrics?
Yeah. So I think actually before I go there, I think looking at what has now happened. So I talked about the pre-COVID, what that situation looked like. And then we have COVID arriving with many, isolation quarantine measures being taken between March and June, depending on where you are in the country. So we see that increase in kids being seen in the EDs, children and adolescents being seen in the EDs. Not only are they being seen more for these mental health issues, they're also being admitted to hospitals more frequently. And they're then being admitted to inpatient psychiatric hospitals more frequently than they were prior to COVID-19. And so I would say, this latter point bears out in our own system. And I will thank a couple of my colleagues for helping me come up with some general numbers here. But on our service, we have seen about an 18% increase in transfers to inpatient psych between 2019 and 2020.
Wow.
Okay, so we went from about 150 a year to about 180 a year. Additionally, I think the increase in these hospital visits, ED visits, PCP visits is that resources have been limited now. So the outpatient mental health services, while they tried to be up and running with telemedicine, it took a little bit of time to get that going for some places. And so there was a bit of a lag. We also saw a slight decrease in admissions between April and then over the summer, I believe, as people were staying away from hospitals due to the virus, but also because that time of year for us in behavioral health is generally a pretty good time of year. School is ending, demands are decreasing, summer's happening. And then we went back in the fall, there was another spike, and that was really when the first or second wave, depending on where you were in the country, was picking up. That being said, too, on the psychiatry end, for the inpatient hospitalizations, inpatient beds pre-COVID were already low for child and adolescent across the country. And then with isolation measures and, infection prevention measures being in place, many of the double occupancy rooms moved down to single occupancy. And so many units were decreasing their numbers rather dramatically.
So we went from having low numbers to having even lower numbers because of all the measures had to be taken for infection prevention.
Lower numbers of inpatient beds, higher number of need for inpatient treatment for a variety of reasons that we can we'll get into with the question you had asked before. And so that's where we are now in COVID.
Now, what's interesting, the reason I asked the question is, this may be my naivete, and that's very possible. If you would have asked me back in February, if we would cause everyone to have isolation and stay home and not go to school, adolescents I'm talking about, what would that do to mental health? With all the focus on bullying and online bullying and all of that, I would have said it's got to make things better. People are at home. They're not in those environments that can cause anxiety or concern. But the exact opposite happened, which surprised me at first, and then it became an issue because we were seeing these patients. But what has caused that? Do we know?
Yeah. Well, so I have some, I think, reasonably well-educated guesses here. But first, I think there was a period of novelty, right, with the quarantine and isolation. It was like an extended snow day. And so there was some fun with that. And I think, again, depending on where you were in the country, you were still able to go about more routine social engagement. But as things became more strict and isolation increased, we know that isolation is not good for our patients who already have anxiety and depression. They may prefer that in the midst of their illness, but that ultimately is not what helps them get better and feel better. In fact, withdrawal and isolation is actually one of the symptoms or behaviors that we look for when we diagnose depression, right? Kids separating from family, kids separating from friends, not wanting to be involved with anything. And so isolation has a huge impact on one's well-being. So if you already have a diagnosis, that's not going to help. The other thing to remember is that for our children and adolescents, this is all school age. So we're talking about kids between the ages of 5 and 18. There is, aside from family and our younger kids, peers are the next thing that is necessary for development. So when you look through Erikson's stages, young kids are learning their conflict is industry versus inferiority, and school helps them build confidence and competence, right? So they're engaging in tasks, they're learning things, and they're able to start working through frustration, okay? When you look at our older kids, our teenagers, those peer interactions are absolutely fundamental to being able to move in to young adulthood, because this is where they're starting to engage in real social relationships. Without that, they're not moving forward, but there's no place to kind of flex those developmental muscles. And so then all conflict kind of turns inward into the family system, which brings up the next point. I think there's much literature and many news stories out there about how the, job loss amongst parents, financial strain, increased conflict at home, in particular with regard to domestic violence because of these stressors, this all impacts children. And so we're getting a second victim-like picture here. There's no space, there's no privacy. And, when quarantine was really restrictive, you couldn't do anything. There were no after-school activities. There was no in-person school. In many places, there was difficulty with technology, with getting kids even hooked in to be able to do virtual school. And all of that puts strain on the family unit and then on the individuals within that family. Kids and adolescents, not excluded from that.
Are you seeing or reading about more than just like depression, anxiety? Are you seeing increases in schizophrenia, eating disorders? And do you think all these things are married together?
So I do suspect that they're all married together. We are certainly seeing more hospitalizations and visits for patients with these diagnoses who are having some decompensation. Certainly anecdotally here, we've seen more eating disorders, more suicide attempts. We are frequently consulted for depression and anxiety. And I think in some ways it's hard to know. We suspect that all of these numbers are increasing, but there's also a limit to our outpatient resources for patients to be seen and evaluated by mental health professionals. And so it may be some time yet before we can say all that.
Knowing that we're getting the vaccine out and it's trickling into the society, and at some point ideally within the next 6 months, we will get back to some semblance of normal. When do you suspect or guess this will all calm down to pre-pandemic levels?
It's a great question, and it's one that I wish I could answer well, but it's rather difficult to say. I anticipate even that when we do return to whatever the normal is going to be, whether that's, 2019-esque or not, we're going to see another uptick in mental and behavioral health concerns amongst children and adolescents because they're going to have to transition back into school. And that's going to be different. And that's always difficult. Our highest times of need in behavioral health tend to be right at the start of school, mid-fall, and then the winter. And so I think this will ebb and flow for a bit. And it will depend on what services are available. But though I do think that once kids go back to school full time, more of them will be engaging in their typical therapies and services that are offered through the school systems.
Is there any historical reference to this, Cristin? And I can't think of a time besides like 1918, 1919 pandemic or the world wars when the entire world had this type of a situation where this trauma-like experience has happened. And I just don't know that we have any real data on how this affects something as simple as anxiety in so many people.
Mm-hmm.
Do you have any historical reference for that?
Yeah, so I don't. I wish I did, and I will happily search further on that for anybody listening, because it's a very intriguing question. So I don't have the historical data, but I do have information from the WHO, who in October had surveyed 130 countries, and more than 60% of them reported disruption in mental health services to vulnerable people. So this isn't an isolated United States problem. This is a global problem, to your point. But I'm happy to look into the historical to see if we have anything in the past that might help inform us here.
Thank you for that. So now let's get to the meat. A lot of people are waiting. They want to know about de-escalation. So we all have patients who now are admitted for multiple reasons for mental health issues. And they may get upset, be hard to control if they're angry or if they're manic or schizophrenic or they're having an issue. And hospitalists, and we've seen this all over the listserv, are asking these questions. What can I do to de-escalate a patient safely? How do I go about that in a pediatric patient? This isn't something we get a lot of experience with. And I'll be frank, at our hospital, my first thing to do is call you all. Usually, if I've consulted you, which I do, you will give us a wonderful thing, what to do in your note. If a patient escalates or gets violent or something, I do these steps. So we follow those, but not everybody has you so closely available. So what can we do?
Yeah. So again, this is such a great topic. And I think the first thing that I would like to highlight is the fact that agitation is a symptom with a very wide range of potential etiologies and or contributing factors. So things like difficulty communicating needs, having an intellectual disability or a developmental delay, having anxiety or psychosis, substance use, delirium, catatonia. I mean, the list goes on, trauma, any acute triggers, all of that can lead to agitation. And so the thing that needs to be kind of first and foremost, along with safety, is there an identifiable cause for this and can I mitigate that issue? Beyond that, I think it's always great to involve psychiatry if you have the resource available. But I know that there are many out there who do not. So when thinking about agitation, there's verbal agitation, there's physical agitation, the latter of which tends to be the one that gets everybody up and running fairly quickly. I think this often happens, or it can happen in our older children and teenagers. The younger kids tend to be a little easier to manage because they can be managed by parents or somebody holding them. Not always, but most of the time in that regard. And I think younger kids, again, in general, they might be easier to manage in some settings just because they are smaller than we are, but they're less readily able to engage in conversation with us. And so that becomes an issue. I think older kids can be very difficult from a physical agitation standpoint and may or may not be more apt to engage in conversation. So one of the things that I like to do, particularly when consulted on these patients, preferably before agitation happens. Sometimes we have the ability to have some foresight and say, this patient has a history of agitation. And so, we want to figure out how to mitigate that if it does occur. The easiest thing to do is to ask the patient and the family what has worked for them in the past. They may come up with a list of things, listening to music, watching this particular YouTube channel, being alone for a minute, or the parents may say, you know what, Ativan has worked really well in the past. So parents may come up with an immediate pharmacological intervention or more behavioral, and both are important to have at the ready. When we think about kids who have a history of agitation, particularly physical agitation, so one of the other things after you've taken this history is to ensure that you've made the room safe. I think this is fairly straightforward in patients who come in already with suicide precautions. Many hospitals have kind of prescriptive procedures that they go through to make sure that there are no cords, no phones, and no items that can be thrown or ripped out. It's a little bit tougher when we're not sure that somebody's going to be agitated, right? So those patients who get admitted and then somewhere during the course of their time with us, they escalate. In that case, again, if psychiatry is not readily available, I think there are some techniques that are helpful. First of which being your safety is primary. And so when you enter the room, making sure that you never turn your back to the patient and making sure that the patient doesn't get between you and the exit. Right? Oftentimes it's helpful to stand kind of on a diagonal so the patient doesn't feel trapped either. So those things can kind of reduce tension. And then it's about trying to calm the room. I suspect by the time that somebody has gotten to the point where there's significant agitation, there are usually multiple people in the room, often saying different things at different volumes. And so you as the primary physician or provider going in and taking over the room as if it were a code. Agitation is a psychiatric emergency, so it should be treated as a code. Certainly physical agitation. I think verbal agitation, we all perhaps are more familiar with kind of how to manage, but it's the physical agitation that can become quite dangerous. Okay, so
no, see, I've never heard it described like that, but that makes complete sense. It's a psychiatric emergency, treat it like a code, go in the room and take over.
Yep. So somebody needs to be in charge. And if that's you, that's you. But going in and starting to calm the room. So that may mean a lot of kids get more activated the more people who are in the room and the more commands or instructions they're being given. Okay. So it should be one person talking to the child or adolescent. One technique that we use is to actually lower your volume below what the patient is using. So if there's a lot of yelling, taking your tone down. Now, caveat to this, it can really backfire. Some kids who have experienced these techniques before get really frustrated by it, but it's a reasonable thing to try.
Can I ask, when you mean lower, you don't mean deepening, like going deeper. You mean quieting how the volume you're talking at?
Yep.
Okay.
I mean, quieting your volume. Sometimes deeper volumes work too. They can resonate a bit more.
Okay.
Not all of us, unfortunately, not all of us have that ability, Tony, but everybody can be a little quieter.
Fair enough. That's a good point.
And then, as you're doing that, really engaging the parents or support person in the room to help you. Now, sometimes that parent or support person is the trigger. And so in that case, it may be helpful to ask them to step out just while you get control of the situation and make sure that everybody's safe.
How do you ask them to help you? Like, or do you ask them to sit next to you? Or if you're in charge of the room, what do you want them to do? Just if they have a way to calm them, to activate that?
Yep. So at least half the time or more, families are already trying to do that. They're already trying to engage. Some are doing it in a very effective way and others aren't because either they haven't seen it before or they're a contributing trigger and haven't figured out how to kind of mitigate that situation. But I ask parents, is there anything that happened? So what happened immediately preceding this event? It's also helpful to ask nursing staff that or anybody who was near the room at the time. And then to the parents, what has been helpful before? Some will say, I have no idea. This has never happened before. Some will say, do you have any goldfish? And eating goldfish works. I've seen the whole spectrum here, but I think parents can be one of your best allies in this, as they often, they always are for us, both in psychiatry and pediatrics. So having the parent be an ally, having the support person be an ally, kind of limiting the number of staff in the room, pending safety for everyone. And then in addition to quieting your voice, being very clear, concrete, and simple in your language. When somebody is really elevated and activated, they aren't going to be able to follow multi-step commands, multi-step instructions. It needs to be very clear. And give choice. Would you like this or would you like this? Very simple. And the two choices should be things that you are providing. So would you like me to turn on music? Or would you like to take a medication? Right?
So not like sit or stand. These are choices you're giving them. Oh, so you can be sit or stand.
The two I just gave were just totally out of the blue. It can be anything. Would you like to sit or would you like to stand while we talk?
Okay. And you're doing that, I assume, to let them feel like they're in control in some way by giving them an option,
Correct.
but also getting them in the direction you want them to go.
You want to engage them and you want them to start moving with you. And one of the other first questions can be, what can I do right now to help you?
Okay.
Sometimes they know, and it's get out of my face. And you say, well, that's not an option right now. I'm here for safety. What can we do together?
In simple language.
Simple, clear language. And then sometimes offering, I don't like to use the word simple again, but simple interventions. Are they hungry? Do they need something to drink? Is there a comfort item that's in the room that got tossed to the side that would be really beneficial to you right now? Again, nothing that's going to hurt if it gets thrown, but if there's a stuffed animal or something that's around, great. Sometimes it's as simple as that. Not always, but sometimes.
Well, this all sounds good so far.
Great.
What else we got? So would you say this works, I don't know, a majority of the time, just doing what you've described right now, walking in the room, quieter voice, establishing control in some way, limiting number of people in, bringing in the parents or caregivers as your ally, and that may mean kicking them out, and then beginning to talk to the patient, asking them, what can we do to help? You've already asked the parents what helps in this situation, giving them clear, simple language, clear, simple instructions. Would you say once you've done this, about half the time this works, or it's impossible to say?
I think probably about half the time this works. And you get to a point where you can engage in a conversation that is, at a more normal volume where everyone in the room is calm and you can work out some plan for whatever's going to happen going forward.
Okay. So what are my next steps if this doesn't work?
So if this doesn't work and you have psychiatry available in your hospital and you have not yet called them, now would be the time to call them. If you don't have psychiatry in your hospital and there is an escalation in physical agitation, again, safety is the number one priority here. So if you have a way to get some backup to help you, whether that is your safety team or security team, or it's extra hands outside of the room just to be able to help make sure that no one gets hurt, this is the time to call in your backup. Then we're probably moving into pharmacological techniques at this point. So what are your medication options? And again, the point or the goal of using a medication intervention is really to address the underlying agitation and distress, to ensure safety, and then to allow further evaluation, right? Because again, agitation is a symptom. It means there's something else going on.
So you're giving this to calm the patient so they don't hurt themselves or someone else, to then get to the bottom of what is going on. What's causing the patient to do this? What's bringing on this symptom of agitation?
Mm-hmm.
Okay.
Right. And at this point, then you probably it's between medication and restraint. And I think nobody likes to use restraint, least of all us. I think it's something that we don't take lightly. We try at all costs as psychiatry really to not restrain patients. It can be very traumatizing, and it does, obviously take away agency. But there are times when you absolutely must for their safety. And in some cases, you need to restrain before you're able even to give a medication. But before we get to restraints, I think when we talk about medications, not every medication that you use for agitation needs to be prescribed by a psychiatrist. I think, there are anxiolytics, for example, like Ativan, that you may be comfortable dosing and using on your own without a psychiatrist, being at the ready, or things like hydroxyzine, something to take the edge off, but that isn't going to totally knock them out. The area where I think more people have a few more questions, appropriately so, is when we get into the use of antipsychotics, which is really our mainstay for significant agitation and aggression in patients. And so these are things like, olanzapine or Zyprexa we use most commonly here at Children's. Olanzapine has a lot of great data. It's been studied in children and adolescents, and it's a very well tolerated antipsychotic for this purpose. So it has very few side effects. very low risk of any cardiac adverse event, is well tolerated, and can be dosed from small kind of all the way up to the larger doses. So you can also give it sublingually as an injection, as a tab, or IV. So it has a variety of routes, which often makes it a nice medication to have on hand for this really significant agitation.
Okay.
And I think when you're thinking about which medication do I use, are you able to get a sense in the room? Is this more anxiety driven? Would this patient benefit from a little bit of Ativan? Where it's not as heavy hitting as an antipsychotic, but will kind of lower the temperature in the room enough to either, take a quick nap and kind of revisit the conversation, or just take the edge off enough that they can talk with you. Versus this is somebody who is trying to put their head through a wall or hit, punch, kick, and is already moving towards restraint, who would really more likely benefit from a Zyprexa or Haldol, something like that. Although we don't use Haldol a lot in kids in this setting because of the risk for extrapyramidal side effects and adverse cardiac effects are higher.
Well, that's going to be my next question. Thank you for bringing that up. So Haldol, extrapyramidal side effects and cardiac side effects. Is there anything in the Zyprexa that you would watch out for or look for as a adverse side effect that concerns you all?
So with Zyprexa or olanzapine, we keep close tabs on the EKG, so monitoring the QTC, as all of our antipsychotics can have the likelihood of prolonging your QTC, although it's quite minimal, on the average of 2 to 5 milliseconds. Again, it's very rare that they would put anybody into a cardiac arrhythmia or torsades, but we do like to have an EKG. Often in these patients where it's a quick onset of agitation, we're okay to give one dose to try and calm things down and then get an EKG, when it's safe to do so. We feel like a 1 to 2 time dose has low risk in these settings, and then we monitor. The other thing we monitor for is any extrapyramidal symptoms. For Zyprexa, we monitor for any stiffness, so just kind of moving the arms and legs around to make sure that we're not getting any worsening stiffness from the medication. It's very, very low risk in Zyprexa. It's higher in things like Risperdal, Haldol, but it is something that we monitor.
That's good to know. And I guess the question a lot of hospitalists would have is, I have no concern because I know you all. So we've been, we worked together for a long time. I know a lot of our CNL or consultant liaison team. But for a new hospitalist or a hospitalist maybe who has to call a psychiatrist who's off-site, when do you want to be woken up for a patient that you're being consulted on? At what point do you want the team to call you?
So I always welcome calls anytime, I think, to help in any situation, answer questions, etc. But I think we would all probably agree, and again, I'm taking liberty to speak for all the psychiatrists out there, including my team, but anytime there's a safety issue like this, where there is a significant escalation in behavior, we want to know because we can help. And I think, again, the more brains, the better. Even if we're not on site, we're happy to help triage by phone. So I think really escalating agitation is definitely something no one should worry about waking us up for.
So I like what we've done. So we've established, so before any agitation starts, we should set the stage in the room in terms of what will keep the patient calm. Is there specific movies or music or something? And then if it's already started, going and taking control of the room, a verbal de-escalation with lowering the volume of your voice, kicking out people who don't need to be there, taking control of the situation, talking to the family, care or guardians, having them as an ally in terms of what can typically will calm the patient down or help them with this agitation they're experiencing. If they're one of the triggers, kicking them out, then trying to talk to the patient, clear, direct, simple language, giving them a choice. If all else fails, you have to go to medication versus restraint. Restraint is always a last resort, only for safety of them or everyone else around them. And then we've talked about in pediatrics, we don't like to use Haldol for pharmacologic restraint or pharmacologic de-escalation, Zyprexa or olanzapine. But before that, Ativan or I always call Atarax for decreased anxiety, trying to figure out what the trigger of this is.
Right.
And then all of this is to calm the agitation, which is a symptom. So to figure out then what's the underlying cause.
Mm-hmm.
Did I understand that appropriately?
That was a beautiful summary.
Oh, that's great. Thank you very much.
I think, and in hearing you do that, I recognize something that I missed that I think is a really important early step in this, which is for any admission, setting clear expectations. That will often help mitigate this. And I think, we've seen a bit more agitation, angst, frustration in kids who have had to wait in the hospital for beds before going to inpatient psychiatric treatment. And so really trying to set the stage, we know that it's hard to be in the hospital. We anticipate, we're going to start the bed search now. It may take us X number of days. We'll keep you updated, but really giving them kind of a walkthrough of how you anticipate the admission will go, knowing that there will be changes to that plan.
Okay.
And then engaging, wonderful. So we're very fortunate to have outstanding child life, music therapy, art therapy here. So engaging those ancillary services can also be exceptionally helpful in keeping everyone calm.
Yeah, I will say one of the groups I miss the most in our COVID era is our pet therapy.
I agree.
Wonderful for
I agree. We need them back. Yeah.
Yeah. Now, Cristin, this was all of the questions I had. I mean, this was a great summary for me as a hospitalist, and I hope for other people who are listening to kind of walk through what to do with a patient like this. And I loved how you did it because you navigate both worlds. You're a hospitalist and a pediatric psychiatrist working in both arenas. So I really loved it. Is there anything we didn't talk about that you felt we should have talked about?
I don't think so. I think I tried to get it all in there. Well, but I will look for that historical context for mental health in a pandemic.
Yeah, that would be great. I mean, I have to tell you, I really appreciated you coming on. This was really helpful. It was a really nice discussion. I hope to have you back on when this is all said and done, and we can talk about now that this is behind us, where do we go, which would be great. But thank you so much for being a part of this.
Oh, it was my pleasure. Thank you so much for the invitation.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast. It takes you to a web page. Create a free username and password. Answer some questions that I write that are not hard. And that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for